Well, welcome to the spinal cord stimulation trial demonstration here at our 7th annual course. We'll be going over some of the pearls for spinal cord stimulation trial. Today we have Boston Scientific's leads and devices today. They've been a great sponsor to us since the first annual, and thank you very much, Boston Scientific. I want to highlight their lead. It's a 16 contact lead, which covers 3 vertebral bodies, which does help in helping programming and getting coverage for the patient's pain. As Dr. Naidu alluded to, you want to pick the correct patient right indication. Once that's found, you're looking on the imaging, looking at the person's MRI, CAT scan, making sure that within the epidural space, the patient has room for you to pass that percutaneous lead up to the T7, 8, 9 interspace. And that's quite important because a lot of patients will have previous hardware, for example, or will have stenosis at a number of levels, giving it a difficult time to get past that lead, or in the case of having a laminectomy with fusion, you're not able to do the procedure at that level or start at that level. So we'll start here, and we're going to be targeting the 2-3 interlaminar space here, and let's go a little more. Actually, let's go to the 1-2 level actually here. Okay, let's go caudal tilt. So we're looking at starting from a 30-degree angle from horizontal, and starting 1 to 1.5 vertebral bodies below the interspace. And let's do here. Okay, so targeting this interspace here, let's go caudal tilt. Other way, please. You see the interspace opening up. Keep going. You see it opening up. Let's go bring the C-arm south, please. And good there. Stop in there. Thank you. That's looking at 1.5 vertebral bodies space levels below. And looking at approximately 30-degree angle towards the inner space there. Headed 1 level above. And as we get closer to it, using loss to resistance syringe to enter the space. Bring it north slightly. That's a little more. Good there, thank you. Need saline? In this case, it's a way to grab some saline here.
Can we fill that up?
Sure. Thanks very much. Yeah, bring it north, please. Thank you. Looking for the loss of resistance. Some loss there.
Go north.
Let's bring the C-arm north, please. Actually, bring it north. And let's reverse the arm, go cranial tilt. Let's get the eye out of our way and go to the tip of the needle, tip of the lead, please. A nice 16 lead contact, an Infineon lead. And I'll have my fellow James Yang, Dr. Yang will bring it up as we discuss some of the
Can you go live, please?
some of the important highlights that the Boston Scientific. Yes, we're going to bring it up T7 as he brings it up. So in Boston, we're using combination therapy. They're approximating their high frequencies at 200 hertz for their combination therapy. Also using standard dorsal column stimulation at approximately 50 to 60 hertz. So you have a good combination, and their algorithms use both to obtain pain coverage for the patient. Okay. Let's get a lateral there, please. Lateral. So depending on where the patient's pain is, will determine what part of the epidural space you're going to be leaving that lead at. So if the patient has low back pain and right leg pain, this could be a very good coverage of the patient's pain. And see, we're well away from the more dorsal side. For ventral side, we're trying to stay in the dorsal portion of the epidural space. Let's get a picture there. So let's do one picture there. So have a good area cut. As you see, it covers almost 3 vertebral bodies of space there with the Infineon lead. There, I got a better picture there. As you see, with the on here. See that? No. Here. Well, I just wanted to highlight the fact that you see the lead is in the ventral portion of the epidural space, which is ultimately where you want it at. You don't want it in the ventral portion, which would be right against the vertebral body. Excellent there. This is what I'm talking about here. And you want that in the more dorsal area rather than the ventral area, which would be here. A lot of times, if you're not sure where you're at, you can get a lateral a lot sooner than we had and see where you're at. A lot of times you'll see maybe that the lead is having no resistance, and you'll see that most likely you're probably in the lateral or the gutter, we would say, which would be the wrong area, which would be more the ventral area. But that's another way of making sure that you're in the right space. Let's put another lead in. We'll put 2 Infineon leads in. Let's go back to the original view. How much time? Let's go north and right the same angle where we were at. And so higher up as well. No, no, don't. Same angle as this, so. And let's bring it south. Puddle tilt. And go live so I can see it on here. Thanks, man. I'll press it. Good. That's good there. Okay. Thank you.
Just put those two plugs in, show your posterior margin, two drills in, show that anterior margin, coded markers are. Close out. Let's take a oval, take a shot on your fluoro, around the 7th and check the relation meter. And on the level below, just
I'm going to limit the amount of
consistent, yeah, and go
X-ray exposure.
superior end plate, just direct it down or something.
Over there. And we're going to try to get in on the other side. A lot of times, what we'll do is come over top if you're putting in 2 leads. And looking at the 30-degree angle from horizontal.
Terrible.
As you see the angle at which we're coming at. Directing towards that interlaminar space.
Splitting mechanisms.
A lot of times we'll anesthetize the tract with 22 gauge 3.5 needle. Give the patient more comfort, apart from the procedural sedation.
Calm down. That was nice of Medtronic to actually take care of it. Yeah, they're doing it.
A little more medially.
Oh, really?
And the same approach can be used to get to the cervical epidural space, and just will require longer leads, and we can probably use these leads and just bring them up to the cervical area. I don't think this cadaver has a cervical, but we would normally can just bring it up to the cervical region. Getting close to the interlaminar space. Again, the saline loss of resistance. It's getting closer. Another way of doing this is to keep yourself safe. Why don't we can go ahead and get a lateral now. To see where we're at, and that way we're keeping ourselves safe, making sure we're not too deep, or making sure we're not too shallow. But another way of doing this is checking a lateral quite quickly and seeing where that needle is at. Live? Okay. Got some loss. A little bit of a os there. Live. Advance a little forward a little more. Live. One thing to note also, we want to get a stronger lateral view. Let's go a little more oblique towards you. live. Go ahead. Go oblique towards you. And other way. Next there, okay. Okay. And at times, yeah, you won't get the loss of resistance that you're looking for. And that's, in this case, we're dealing with cadaver. But what we can do is just use the lead to see if you're in the epidural space. Very good. Just and the rim there. Live. There we go. Let's see it from the lateral view. See, and bring that lead up. As you see, we're in the dorsal portion of the epidural space, which is where we want to be. Okay, let's go back to AP view. But now we want to see, well, making sure that lead is not veering off too heavily to the left or the right. It's pretty much in the middle. We'll have Dr. Ying bring that lead up. Excellent. Not really steering very well. Try to turn it to the left. Not steering well.
Stuck to the right.
Not stuck to the right there? Okay. Sometimes if it stops steering well and we need more curved stylet. See the lead slowly turning to the left and some low movements. I tend to kind of turn to one side and then push. Get some direction on that stylet, on that lead first of all, before pushing it in. I'm going to bring this lead up to the more left side of the epidural space at the same levels. And bring it up there. Go ahead and bring that up, James. Okay. And we're bringing it up to the, well, he's bringing up the T7, the T9 level, approximately. Let's keep it on the left side. We then, with the technologists from Boston Scientific, we'd connect up the leads. We would talk to the patient, seeing where they're getting coverage and stimulation of tingling and light touch sensation, because we're stimulating the dorsal columns, of course, and making sure that's covering the areas and paresthesias in the areas where they normally hurt in the low back or the one of the extremities. And then we'll be fixating the leads without suturing to the low back area using a stay fixed bandage and get them over to the recovery area or further programming, okay? But I see the two leads there. Now let's get another lateral to see where the leads are in the lateral space, making sure that also has ended up in the more dorsal portion of the epidural space. there. Yeah, good. Yeah, it's a little bit overlap, but overall good. Okay. And that wraps up the spinal cord stimulation trial. Thank you very much.